Hi, everybody. Welcome. Good afternoon, Wednesday afternoon. Oh my gosh. Look, we've just got 46 people just joined the room. Oh my goodness, how wonderful is that? Welcome to a PCNA webinar on a Wednesday afternoon. Now, we're just going to give people a minute to join. So this is my favourite part for those who are here each fortnight, where I'd love you to, if you can, pop in the chat just where you're joining us from and what role you do. I can see some familiar faces there. Hi, Mary. Hi, Jenica. Hi, Nicole. Hi, Anna. Hi, Julie. Who's going to go first in the chat? We got anyone there? We've got 52 people. Naomi. Hi, Naomi from EPC. Megan. Hi, Megan from Tamworth. So it's very cool. Would you give us a couple more minutes? Hi, Louise, Adelaide. Louise is here every time. Thank you for coming back, Louise. Justine. Hi, Emily. Hi, Angela. Someone has, I think it might be Andioni, has their microphone off mute. Hi, Emily from Peacock. Hi, Justine from WA. Hi, Abdul. Hi, Emily. Who else? Hi, Cherie from Ballina. Hi, Gay. I was just saying before you joined that Meer, Amy, and Annmarie are some powerful draw cards because I'm quite impressed with how many people are joining us today. So we're very, very grateful. Therese from Sydney, hi. Hi, Tanya. Hi, Lara. Hi, Helen. Hi, Wendy. Thank you, everyone, for joining us. We'll give everyone 30 more seconds and then we'll get going. Hi, Mira. Thank you for coming. Alison from Safer Care. Hi, Julie from Tassie. It's just incredible how many people from around Australia. Yeah, all right. So I think we might get going. That list is long. So thank you very much, all of you, for joining us for another PCNA webinar. So my name is Sarah, for those that haven't met me, and today we are going to talk about a topic that I think is relevant to everyone in healthcare, and particularly as palliative care nurses, something that we can see on a daily basis. And you can never learn enough about delirium. So we've invited Meer, Amy, and Annmarie to speak with us today, and it's going to be a conversation really pitched at what I would say is an advanced practice level of knowledge. So we're really hoping that the people who are joining us already know a fair bit about delirium, and we're pitching this really at a level where Annmarie, Amy, and Meer are going to give us a refresher and have a conversation about how we manage this as advanced practice nurses. So before we start, I'm just going to do an acknowledgement of country. So at PCNA, we acknowledge that we live on the sacred lands of the First Nations people of Australia. Each person who's joining us today joins from a different location, and I'm in Darwin on the lands of the Larrakia people. PCNA recognise and respect that this land has sovereignty that was never ceded, and we acknowledge that the air, the waterways, and the land that we work on hold deep significance for the First Nations people of Australia. We honour them, we admire and respect the Aboriginal and Torres Strait Islander people who represent the oldest continuous culture in the world. Their strength and resilience and deep interconnectedness to all living things continue to give us strength as we do our work in palliative care. So thank you very much, everyone, for joining us. We have 76 people here with us today. It's super exciting. The last things I want to say before we get going is just if you can turn your camera on and turn your microphone off. As we do the talk today, the chat today, you can pop questions in the chat. And if we have time, we will come back to them. But if we don't, we may need to answer some of the questions at a later point via email, but we'll make sure that we get to them, just only because we've got so many people joining us today. So before we get going on delirium, I just want to introduce our speakers. So Amy, Meer, and Annmarie, can you please wave? There we go. So I'll introduce Professor Meer Agar. Meer, can you wave for me? I think everyone knows Meer, but there's Meer. Professor Meer Agar is the Director of Impact at University of Technology, Sydney, and is a staff specialist in palliative care medicine at Southwestern Sydney Hospital. And she's an internationally recognised leader in delirium research and advocates for interdisciplinary, evidence-based and compassionate approaches in delirium care. I'm hoping that's accurate or semi-accurate, Mira. All right, and then Annmarie, can you please wave for me? So Dr. Annmarie Hosie is an Associate Professor in Palliative Care Nursing at the University of Sydney. And she has done research, and her research has been dedicated to improving quality of life for older people with advanced illness. She's a leading expert in non-pharmacological approaches to delirium care and has extensive experience in across a range of research methodologies. I'm hoping that was also accurate.
I'll just change one little thing, Sarah. I'm from the University of Notre Dame, Australia, and I'm in Sydney.
Thanks, Annmarie.
I did my undergraduate in the University of Sydney, so long time ago.
Right. Thank you, Annmarie. And then Amy. Amy, can you give us a wave? So Amy is Dr. Amy Montgomery, is a postdoctoral research fellow at Impact, and she is working at UTS also, and she's an aged care nurse practitioner specialising in delirium education, simulation-based training, and developing models of care for delirium prevention and recovery. So each three of these wonderful women are really experts in the field, and we're very, very lucky to have you here. Now, before we get going, James, are we all pinned? Are we big for everyone? Speaker? Yeah, can someone give me a thumbs up just to tell me whether we're big? Are we big for everyone else? Yes, okay, that's all right. Let me know if we're not. Just you're big. Thank you, Anna. So we're going to get started. And my first question is going to be directed at Amy. So Amy, I just wondered if we could start somewhere simple. And I promise for those listening in thinking to yourself, oh my gosh, I hope this gets better. We're just going to start simple because I think it's an important place to start, which is my question for you, Amy, is what is delirium? And why do you think that it's so commonly missed in palliative care settings?
So, hello everyone. I just wanted to say that I am working and sitting currently on Gundagara country in the beautiful Southern Highlands of New South Wales. So delirium is an acute change in mental status. It can be inattention, disorganized thinking, disorientation, and it happens in an acute, rapid manner. So it's not a slow, progressive change in someone's cognition or orientation like we would see typically with dementia. It's something that happens in a couple of days to hours where all of a sudden the person isn't acting like how they would normally act. They may all of a sudden have become really confused, disorientated. They could have inattention, which is they can't maintain focus on you or a conversation. They're really easily distracted. They could have visual or perception disturbances or visual hallucinations or auditory hallucinations, and it can be quite frightening for them. There's 3 different types of delirium. The first one is your hyperactive form of delirium. This one's really normally always really noted because the person's in this hypervigilant, hyper-agitated state. I kind of refer it to like a meerkat that's had too much Red Bull. So they're scurrying around, they're looking everywhere, they can't sit still, they're over here, then they're over there, and they quite often don't sleep. So for hospital settings, when someone is in hospital with a hyperactive delirium, they're normally very well recognised because it has the doctors madly paging the doctors in the middle of the night, being like, please come and help us, this patient won't sleep. The most common type and most unrecognised type of delirium is hyperactive. And this is, I think, is probably one of the reasons why it's quite often not detected in palliative care, because this person is most often sleeping, very lethargic during the day, not really verbally engaging. You go over, you wake them up, they may open their eyes and look around for a couple of seconds, but they can't maintain focus on you and quite often can't maintain keeping their eyes open. And most people put this down to normal sort of fatigue in palliative care, complex disease, or end of life. They're quite often a really compliant patient. So you get so busy with the other ones that you quite often would, I'll just come back to them. I'll just let them rest. They're really unwell. I'll go and do other things. And it takes a couple of shifts for people to realize that that particular person hasn't been moving, getting out of bed, engaging, eating, drinking, that kind of thing. And then the mixed delirium, where they flip between this hypoactive state and this hyperactive state. So they'll go from being really hypervigilant, really distressed, agitated, moving around, really inattentive, to that really hypoactive state where they're really sleepy, drowsy, not really able to maintain a lot of eye opening, withdrawn, and it's quite often in reverse to their normal sleep-wake cycle as well. So all of a sudden they're sleeping all day and they're awake all night. So that's basically what delirium is in the 3 different types in a nutshell. I think also too, delirium is quite often missed because people just think that it's part of their disease trajectory, particularly depending on the underlying disease pathology that they have. People might put it down to some of these symptoms just being a normal presentation for maybe their potential disease trajectory, and it may not be detected as being reversible.
Thanks, Amy. I love that. I've never heard a hyperactive delirium described like a meerkat, but I'm never ever going to forget that. So that's lovely. Thank you for that, Meera and Annmarie. Have you got anything else you wanted to add around why do you think delirium can be missed?
Yes, I agree with everything Amy said. I think the thing is, because it is so common when people are sick, we've almost just become accustomed to it. And I think the other reason is that nurses often, most nurses, we don't learn the diagnostic criteria for it in our training. So, for example, it took me 20 years to understand what delirium was. I've been a nurse for 20 years and I would have seen hundreds of people, if not more, with delirium. But if we don't get taught what it is and understand those components of it, we just can't quite put our finger on what it is. So I think if we learn the diagnostic criteria and we learn how common it is in palliative care, then we'll be on the lookout for it and we'll see it every day. But the other thing too is that it's always associated with some sort of physiological change it's caused by these physiological changes in the body. And if we think, oh, the person's very sick, what's going on is normal for them, but delirium is never normal.
Yeah.
It's delirium. So whether or not it's common in our setting or whether or not it's expected, it's still delirium, and we've got to take, and it's serious. So I think it's to do with the fact we just see it all the time, and we just think that's par for the course.
Yeah.
It's also longitudinal, and so it does require team collaboration because the changes fluctuate, and so we actually have to communicate with each other and describe those changes over time. And fundamentally, the issue is inattention, and inattention is actually quite a difficult concept to assess and to notice. We're used to thinking about hallucinations and agitation and all of those things that are very visible, but fundamentally, delirium is a disorder of inattention. And we have to learn how to assess that.
Thank you. And that's why I love the description of the meerkat, right? Like that's such a good hyper-attentive description, right? We just need to think of an animal that does the hypo-attentive, like a sloth, maybe. So I'm going to ask Annmarie another question now. So I would like to ask you, so how do you think delirium affects patients and families and staff? That's quite a big one. And what strategies do you think are useful? Because I think this is the big question. What do you think we can do as palliative care nurses to help reduce that distress?
So the distress, I will talk about distress, but I suppose all the different features of delirium affect the patient in different ways, which is probably another reason why delirium is hard to recognise all the time, because it can be so different for each person. People have different set kind of combinations of symptoms. But generally speaking, most of the symptoms or the features of delirium are not enjoyable. So, for example, you know, having hallucinations or not being able to speak properly or not knowing where you are or not understanding what's going on or not being able to sleep these are not fun things for people. So there's distress associated with that. The other thing is that the emotional aspects of delirium, probably the most common emotion of patients with delirium is fear, but there's a whole range of emotions that people can feel. They can also feel very angry. They can feel bewildered, lonely, ashamed, and then often afterwards they'll feel quite ashamed and embarrassed about the things that they said or did. But the fear is probably underpins a lot of the behaviour that we would say is agitation, but it's people, if you're frightened, you're going to want to run away or fight. So underlying these kind of what we say were difficult kind of behaviours is, I would say, almost always fear. For care in a family, you're looking upon someone who is changed so suddenly and dramatically, saying and doing things they wouldn't normally do. That is very distressing. And in palliative care, often I think family have a real sense when this is happening that the person is close to dying. So it's not just that they're having these really strange symptoms that they can't quite work out, but they think that this must mean the person's dying. And sometimes it is. So they link the two things. And then the other, and care, and like us, you know, in terms of nurses, doctors, and other people looking after the patient, delirium can be very stressful. I think it's more stressful when we don't know what it is, and when we feel alone. Nurses in particular can feel very alone at night time. Junior nurses trying to work out what's going on, have whole wards, you know, full of people that they are also caring for. So there's so I would say in the mix here is a whole cauldron of fear, confusion, so fear and anxiety and confusion. And then I think in terms of feeling ashamed and guilty, I think as staff we can feel that as well, because we might realise later what we've missed or what we could have done. And then the second part of your question, Sarah, was we had a conversation about this earlier. We've just done some research in 4 palliative care units over the last couple of years, and part of that project was we interviewed patients, family, and staff about what not just what delirium was like, but what helped. We said and we had some really profound findings, and what everyone said helped, and overwhelmingly said helped, and there's examples of how it helped, was the family being present, someone who loved them, knew them, and the staff who were caring, compassionate, listened, validated what the person was going through, explained to them what was happening, and helped them. And all these things help people feel safe. It also helped some people return to awareness of what was going on, like sometimes like that. Just someone that they knew calling them by name. So the interpersonal aspects of care in palliative care units was profoundly the most effective way of responding to that person in great distress. And when it didn't happen, there was harms. And when we asked patients what they wanted us to do better, they said, I wanted people to tell me what's going on, and I also want to know how to stop this coming back again. We think of prevention as being when the person first comes into the ward, but often, really, I'm starting to think, well, prevention can be just as useful, prevention strategies and talking to people just as useful immediately after the event, because that's when people want to know. So I think what I would say to everyone here today is that there's other things we can do, clearly, in terms of the clinical response, but in the immediate distress of delirium, it is the ways of communicating with and being with the person that really make a difference to them. So that's, but I mean, I might let others talk about the clinical interventions.
Annmarie, thank you. It's in some ways very profound, isn't it, really, that we kind of go into these homes, or we're in a unit with a patient who's got a delirium, and it's and you kind of, as a nurse, you might think, oh, what do I do? How do I be? But actually it's our presence, right? Isn't it? It's our, you know, core communication skills. It really is what is in our toolkit already, which is profoundly important. And from the mouth of the patients and the family members, you know. Yeah.
Everyone said.
Meera and Amy, have you got anything else you'd like to say about the impact on families and carers and even staff too?
I think we have to not underestimate the system impacts that this impacts on individuals, but a lot of our responses are driven by system-wide policies around risk and risk aversion. And so I think just being conscious about what we're responding to and the impact on whom can be really important, and really taking the moment to actually think about it from the person we have in front of us and their perspective, rather than moving sort of into that reactive, risk-driven, policy-driven perspective without really thinking about how does that apply to this person that I have right in front of me.
Absolutely. And actually it's one of those things where it's a moment that will stay in people's memory, won't it? The carers and the loved ones' memory about their loved one's illness forever, when it's done right and not right. So, or well and not well. Thank you, Annmarie. I'm going to ask Amy a question. So, you know, I asked you at the start, Amy, why do we think delirium can be missed? What signs or red flags do you use or do you think would be helpful for people to know about to pick up delirium early? Is it too tricky a question, Amy?
No, I don't think so. It's actually can be quite simple, actually. And the first thing is that red flag that you know that that patient or that person is not the same as your last interaction that you had with them.
Yeah.
And it may only be really subtle, but if you ever have an interaction with a client or a person, and during that interaction you're thinking something just doesn't seem right, trust your gut. Then go on and do a delirium screen or a comprehensive delirium assessment. Or if you've got the family saying, you know, this is not my wife, this is not my husband, this is not my dad, this is not my mum, they're the big red flags that need you to think delirium and prompts you to do a bit of detective work to find out, is this actually delirium? What's the underlying reversible cause? So the most simplest thing, if you don't have anything on you or you can't remember any of the delirium tools on the top of your head and you're in someone's house, you can simply go, is this normal for them?
Yeah.
Do you have concerns that they've had a change in their attention, their orientation, any disorganized thinking, and any of those subtle red flags? It prompts you to think delirium, and think delirium until otherwise proven. Because the faster you detect delirium and the quicker you find the underlying cause and you implement the treatment, the shorter that person's duration of delirium will be, the shorter their distress will be, and the less likely they're going to have significant adverse outcomes. My favorite probably delirium screening tool is the 4AT. You don't need specialized education or training to do it. You can even train up the family to be able to do it. It takes 2 to 4 minutes. It has a mobile phone app, so you can download it onto your phone. The questions pop up right there. You literally can click the boxes and it will give the score for you. Scores of 4 or more indicate it's likely a delirium, and it prompts you to then go and do some delirium detective work. There's more sophisticated screening tools out there like the confusion assessment method, but you do need to do a cognitive screen before doing the CAM, and you need to actually, like Meera said before, really be confident in your ability to detect inattention. So if you don't have that ability or you don't have the confidence to detect inattention, I'd suggest go with the 4AT rather than the CAM. Also, I've put in the chat a link to 2 delirium brochures that can be given to family members as well. It helps them to recognize what delirium might be, but also helps them go through that they're at risk of having a delirium and how they can prevent it as well. And
Thanks,
I'll also put in the chat the link to the 4AT website, because I'll have the instructions on how to download the free app for your phone as well.
Thank you. It actually highlights it. I'm learning so much here. This is great. It highlights to me, like, how important this therapeutic relationship is, an ongoing relationship with the patient or a carer, or even just that, even what you're saying about asking the carer, is this different? Like, they're just such important pieces in the puzzle, aren't they? So look, thank you very much. That was very helpful, Amy. I'm then going to ask, so poor Mira. Mira's just sitting here. I promise I'll ask you some questions later, Mira. But Amy, I wanted to ask you, I'm all about, because I go into a home and I forget things very quickly. I'm all about a simple, like, framework or mnemonic, is that the right word, to help me remember how to assess something. So I'm advocating for all of us to have something simple. Amy, have you got something that nurses here can use to assess and remember what to assess for in a delirium?
Yeah, so my favorite one, there's a few out there. My favorite one is pinches me kindly. So it's, it stands for the different things that you're going to detect. And a hospital that I work really closely with, they put it down in their clinical notes, like when they do the A to G assessment, when they get to D for disability, they then put pinches me kindly in there. And it basically stands for pain. So have they got pain? Is it undertreated? Have they had too much pain relief and they're really sensitive to opioids? Infection. So looking for things more than just a urinary tract infection. I think my biggest pet peeve, particularly if it's a woman who's in her 80s, everyone does an MSU and looks for a urinary tract infection. And if they find the urinary tract infection, they stop looking for further causes. And if I could have like one take-home message for anyone today, that delirium most of the time is multifactorial. So don't just stop looking when you find the first thing. Keep going through your comprehensive assessment, because you'll find there's more than one underlying etiology. But it could be a chest infection, cellulitis, any kind of infection. Then we're going to look at nutrition, constipation. They kind of go hand in hand as well. If someone's really constipated, they're not going to be necessarily eating very well. If they're don't have a lot of nutrients and fiber, they're likely to get constipated. Malnourishment can cause a delirium, and constipation and pain are probably the two biggest causes of delirium that I see. Yeah. Hydration, so dehydration, can cause delirium, particularly if there's shift in electrolytes as well. A lack of mobility, so really important to look at, are they moving around? And encouraging exercise is a really good way to help pull them out of a delirium, but also to prevent the delirium from occurring. Sleep is so fundamentally important, and looking to see if they have a change in their sleep-wake cycle. So asking the family, what's their normal sleep-wake cycle? All of a sudden, are they awake all night and that's not normal for them? There are people who that's normal. If they do normal night duties, it's normal for them to be awake. But me, I like to be in bed by 9 p.m. So if I'm awake at 3 a.m. bouncing off a wall, that's not normal for me. But sleep actually, and getting someone back into their normal sleep-wake cycle is probably one of the best interventions you can do to help them pull themselves out of that delirium. Sleep hygiene is really important. So making sure it's nice, bright light during the day, but really dark environment at nighttime, because we need that melatonin to come into the brain to tell us to go to sleep. Looking at medications, and this is really particularly important in palliative care or even end-of-life care, when people all of a sudden can't maybe swallow their medications anymore. I see it a lot in Parkinson's disease, where they're no longer being able to swallow their Parkinson's disease tablets, and they become very delirious very quickly. So having a look to see, have there been any changes in their medications, any newly introduced medications, any medications that have been ceased, and also preempting that. So if you have someone, for example, with Parkinson's disease, and they're likely going to lose their ability to swallow in the near future, you need to think about switching them over to another sort of formulation, like a patch, for some of their medications. They might be withdrawing off medications as well. They might be withdrawing off nicotine or alcohol. So those things are also important to consider. Also need to consider the environment. Do they have their glasses on? Do they have their hearing aids in? Are they in a really dark room and they don't have their glasses on? And now they're misinterpreting the environment. Like, I'm very visually impaired. So if I'm in a hospital room without glasses on, I think the IV pole's a person standing in my room. And the environment can actually cause significant havoc on the brain and make people have visual hallucinations and different perceptions. Making sure it's not too overstimulating of an environment either. So I think we've all had those moments where there's just too much noise going on and we all go a little bit haywire. But also making sure that there's engagement in the environment as well, because our brains also don't like to have nothing to engage with. You'll kind of go to sleep like a computer. So we need to make sure that we're giving people meaningful activities to do during the day to keep them engaged. And then most importantly, be really kind. And like, that's what Annmarie said before, with that really humanistic approach to care, making sure that you're not arguing with them. You're not saying, yes, quick, run away, there's spiders. You're acknowledging that they can see these things and they're very distressed, but you're constantly reminding them that you're safe. And also educating the family, which is really empowering for the family to know what's actually going on for them, because it is very distressing for them. So pinches me kindly.
Right. Oh, wait for it, Amy. I took notes then. So if anyone was missing them, I'm going to repeat them again because it's a great mnemonic. So P for pain,
yeah.
I for infection, N for nutrition, C for constipation, H for hydration, M for mobility, E for exercise, S for sleep, M for medications, E for environment, and kindly.
Yes.
Love it. Thanks very much. I've never heard that one before, and that's awesome. I think we might actually. I've got a question, and I'm going to ask this to direct this to Mira. I'm going to play. Look, sometimes I've got historical terms that I think I've used over the years that I think might not be accurate. So I've often heard, and I started in palliative care when the term terminal restlessness or refractory delirium or what else was it? Terminal agitation have been used. And that was something that we used a lot 15 years ago. Mira, what I'm asking is, so for a delirium that is happening at perhaps the end of life and a person's very agitated, is there a correct term? Are we using terminal restlessness?
So I think delirium is a medical condition, and so someone either has a delirium or they do not. And so that's the first part of the equation. And then I think, as with any other syndrome or symptom, we will describe the contextual context and the ceilings of care and the goals of care and the trajectory of the underlying illness in that context. And the problem with using catch-all sort of terms such as terminal restlessness or terminal agitation, you're just describing a pattern. The problem is that one clinician describing terminal agitation, whatever that is, in their mind is not communicating to another clinician what actually that is. And the bigger problem is it leads to a pattern recognition response and often a pharmacological response, and doesn't get us into this clinical decision-making assessment, really thinking about why this person has delirium, what are the goals of care for the delirium, but what's also the goals of care for the underlying illness, what are the goals of care for the intercurrent problem, and really going back to that assessment and unpacking exactly what's happening and what are the wishes of the person in this scenario, and then building a management plan. So, no, I think our view, and it is our view, is that the words such as terminal agitation, terminal restlessness describe something, and we actually don't have a unified definition of what that actually is describing. It's not diagnostic and really are not helpful. And no, I think that there are people who have delirium where the underlying cause is irreversible, and we know that delirium will continue until that person dies. So just describe it as such in a really descriptive way, to say this is a delirium that now is irreversible, and what are the irreversible factors that are contributing to that, and what are the ceilings of care for those particular issues for that person based on their wishes.
Yeah. So in other words, perhaps the term is unhelpful because it kind of stops the conversation and makes it stops the assessment, the ongoing assessment, and the kind of broader thinking about what's next for this person and what's the context. And yeah, okay. Thanks, Mira. I hope that answered. There's actually a question in the chat, but we might come back to it at the end about terminal restlessness.
Can I add to everything Mira's just said? But in the across a whole range of different settings over the years, there is generally different terms for delirium in different settings that people have adopted, and as we've come to learn more about delirium, the recommendation for all of those settings is care is we stop using those jargon kind of terms and we use the word delirium. Like Mira said, is it delirium? It is either delirium or it isn't. So an example from the ICU, they could call it ICU psychosis, and they said, well, actually, it's delirium.
Yeah.
So it's not just us in palliative care who do it. We all come up with we form our kind of setting or specialty specific language, but it's not precise. So it's not just a problem in palliative care, it's everywhere, but I think palliative care, we've held on to it much longer than other settings have.
Yeah. It's kind of reassuring that there are other industries that have the same it makes complete sense to me that let's just call it what it is, which is a delirium, right? Like it promises.
And restlessness and agitation can be due to other things such as pain and psychological distress, and so if it distracts from actually doing a proper assessment, and sometimes it's not actually delirium at all, and it's assumed to be that. So it's just an observation. Restlessness and agitation are an observation or something someone describes to you, and then you do a further assessment to work out with your clinical sort of detective hat on why they're experiencing that. The other thing is agitation today might be pain, and then later in the day it might be related to the delirium, and then later in the day it's due to something else. And so even the same symptom can be due to different things as the day progresses, which is another assumption people make, that it's once you've diagnosed it once, it's the same thing for the rest of the day.
I love that. All right. We're not going to say no more terminal restlessness, no more terminal delirium. We've heard it here. 80 people have heard. Okay, so now Annmarie, this is kind of related. I promise, for those who are thinking to themselves, when are we going to talk about the medications? We are going to talk about the medications, but before we do that, I want to talk about non-pharmacological strategies for preventing, and probably more, let's talk about more managing delirium, and particularly when it's not reversible. And I'm thinking, walk into a home and you've done a great assessment and you've realized that this person's got some kind of delirium that you've identified that you can't reverse for some reason. What non-pharmacological tools do you pull out, Annmarie, to help in that situation?
Well, I wish I knew this when I was working clinically, and it might have been better for the people that I did see when I walked into the house and they had delirium. Just kind of gently changing a couple of things there is, you don't know a delirium is reversible when you first determine the patient has a delirium. You don't, because part of the assessment for delirium is identifying the causes. So as Amy said before, it's usually multiple causes, and so someone may be very close to dying, but there may be some things going on for them that they're causing the delirium that we can't reverse. But at the same time, that person who's dying might have 1,000 mils in their bladder. They might be hot, they might be cold, they might be in pain. So I don't like even the term irreversible delirium, because you can only know that in retrospect.
Yeah.
So at the time, you're working at what's going on for this person physically, emotionally. What can we help? How can we reduce the stress that they're under? And so that, I suppose, yeah, I would not say, well, the person's dying with not much we can do. I would say, what can we do? At the same time, recognising that, the person may die still with delirium and symptoms of delirium, but we won't know that until then. So going in with what's the opposite of futile approach? Going in with a positive approach to what can we do to help the person, which I think is what we tend to do as nurses. How can we make the person more comfortable, relieve their anxiety, distress. So in terms of non-pharmacological approaches, that's also a funny kind of term, isn't it? Because, there's so many things, there's everything but drugs. So, does that include, the way of speaking to people? But in the delirium research kind of world, it kind of refers to the basic things like sleep, exercise, eating and drinking, having glasses, being able to see and hear and move around. So a lot of those things, depending on where the person's at, they might not be able to do. And the other thing is that we know that putting those things all together will reduce the risk of delirium, but we don't know that there's not evidence that if you put all those things in place that you're going to reverse the delirium any more quickly than with that. However, those things are so fundamental that everyone, we should be paying attention to all of those things. So I think in terms of evidence-wise, there's really good evidence we can reduce the risk of delirium by paying attention to those fundamental things human beings need in a systematic way. In terms of going in and thinking we're going to put all this in place and it's going to fix their delirium, we don't know for sure, because there's a whole range of things going on for the person. So I think my take-home message would be always attend to the fundamental aspects of care, no matter whether the person has delirium or not, they matter. And look for all sorts of reasons why the person may be stressed, distressed. And I don't know, Meer and Amy might not agree with me, but the more I think about delirium, the more I think this is all, if the person is under a weight of stress, can't cope. So how can we reduce the stress, whether it's physical, emotional, environmental, even spiritual? So yeah, that's I suppose it's a roundabout kind of long-winded answer to your question, but I think there's a lot we can do if we remember the basics.
And I think it tends to what you said at the start about your research, that really what's important is being present and acknowledging what's going on for the family, for the person, and that it's
trying to understand.
Yeah, complicated and as simple as that.
Yes. We'll always miss something, because there's so many things that could be going on. We will miss things, but that's why having systematic kind of approaches helps us when we're busy and got a lot on our plates.
Yeah. Now I am going to ask Meer a follow-up question. So Annmarie's talked a little bit about non-pharmacological strategies to manage a delirium. Now, as I'm saying this question out loud, I'm thinking to myself, oh, this is so not worded right. But my question is around medications. When's the appropriate time to use a medication? If you've got a patient with a delirium that you've assessed and you've put in, whatever strategy it is to reverse the delirium, but you've also got a patient in front of you who is profoundly distressed and agitated, and you've done all of the non-pharmacological strategies as well. Which ones, Meer, and when?
So I'm going to start with the biology of delirium, and I think, if we think about pain, we know how pain is mediated from a biological perspective, and we know how opioids work on that pathway. And I think if we think of that as the premise for how we should understand the way we use medications, then we need to actually go back to that sort of fundamental principle in terms of delirium. So many of us, when we went and did our initial degree, would have learnt this sort of very simplistic model that delirium was related to an imbalance between dopamine and acetylcholine. Actually, though neurotransmitters are really some element in the sort of biological pathways of delirium, it's actually really come to light that there's a much more complex pathophysiology going on, and metabolic issues within your brain, neuroinflammation, and much more complex biological pathways are probably much more fundamentally, and neuronal connectivity are much more likely to be the actual drivers of delirium as a syndrome, which really then puts significant doubts in terms of the biological mechanism for some of or most of the medications that are commonly used in the delirium space, namely antipsychotics and benzodiazepines. And so, I think we have to really realise that fundamentally we currently don't have a medication that is targeting a biological pathway in a way that we understand from a preclinical perspective and that has panned out to clinical evidence. And we don't have any registered medicine for a delirium indication internationally. And so that's, I think, the first thing to say. And I think that's really important, that with all our pharmacological strategies, we actually have to think, what's the biological basis of what we're doing? So then, I think we have to think about, what we're not actually treating the delirium. So that's then really the next sort of, if you take that line of thinking, we're not using a medication to treat delirium, and we currently don't have a medication that is in that ballpark that we can have access, and know that's a rapidly evolving field, and we're hopeful that maybe that will change in our clinical careers and really fundamentally change the landscape. And so the first thing I think is, what actually is the target symptom? And sometimes there are several symptoms. And so I would be thinking about, is it perceptual disturbance? And hallucinations and delusions are within that. And I would get down to that granular level. I wouldn't even say perceptual disturbance. I would be thinking, is it a hallucination? Is it a delusion? Is it both? And what is the impact of that hallucination? Because there are many people who are having hallucinations who are aware that it's not real, with information, are not distressed by that, are not causing harm to others. And actually for them, their goal is to maintain the moments of cognition that they have, and that's important to them. So that's really, I think, when you're thinking about the target, getting down to that very granular and detailed level. And then physical agitation, again, is, what actually is it? Is it just someone moving in the bed? Are they plucking in the air? What's the distress to them? What's the harm to others? Are we thinking about the issue of someone getting out of bed and falling? And then the issue is, well, actually, would a medication actually just increase the risk of falls, if that's what our end goal is? And so I think, what's the target and what's the goal? They're two separate questions, because the target for one person and then the goal of treatment for that person might be quite different to the same target, but in a different person. So that's, I think, the first thing, and really being very detailed in the way we describe that in our decision making, in our clinical notes. So the next person caring for that person can see what we were thinking at that time, because it does evolve and change, and we have to almost go through that decision making every time we're thinking about a pharmacological or the next dose, for example. And then I think it's really about thinking about what is the best available medication based on what we know about how the drug works for that scenario. And we actually are often operating in an evidence-free zone. We're working on first principles, and we're working in an off-label prescribing context. And so informed and shared decision making around that, and our colleagues in the older age psychiatry are very clear about the consent and decision making when they're using antipsychotics, say for someone living with dementia. And I think we should take a leaf from that book and use the same kinds of principles, that this should be a really informed, shared decision with the person with delirium if possible. And often that is actually possible, or they can give you a general sense of what's important to them and how important maintaining cognition is, and how important relieving the distress that they might be experiencing from a particular symptom is. And they can give you a range of where they would like that equation to land. And then I think it's about, sometimes a single dose and a low dose, and watching and seeing what happens. And I think we jump too quickly to regular dosing. We jump too quickly to quite large dosing, and then going back and reassessing. And I think we have to think about delirium as a medical emergency. And so senior level people should be involved in that process. It's like a pain crisis. If you actually are requiring prescribing of a medicine, we actually need to make sure, particularly when we're thinking in a ward environment, that we're not leaving this quite complex decision to the most junior members of the team, and that they feel supported, and that reassessment happens. And then I think as required medication is another complex issue. Again, we have to be really specific about the indication, and I've seen on charts, agitation / hallucinations / breathlessness / and really, actually, we should be very specific about, if this is for hallucinations, that's how the PRN dosing should be charted, and we have to really be careful we don't have indication creep. If that's the intention and that's the shared decision that's been made with the person or their substitute decision maker, then we really need to stick to that parameter. And if the situation needs to be reassessed, have another conversation, and then articulate the new management plan. And it's no different to how we would think about adding an anti-neuropathic. If someone has neuropathic pain, we would be thinking about that from a really biological, assessment-driven process. And I think delirium should be the same. With the proviso, we're actually working with little evidence, and also evidence that actually they don't make a difference to delirium overall. And we also have evidence that actually their impact on symptoms is probably not very, very strong, and the mechanism of action is probably much more driven around sedation rather than actually changing perceptual disturbances, though you would probably need a lot more studies just purely looking at hallucinations to more definitively answer that question. But there isn't this resounding evidence that shows us that the symptoms that we think these medications treat are actually doing that in the way we think they might be.
Yeah, Mira, thank you for that. It's such a great answer. And I just, as a little summary, I love, because I've never, that was a different way of talking about a different answer to that question than I've ever really heard. And I love that. I think as palliative care nurses, we love mechanism of pain, therefore that's a matching medication. And that I liked the fact that you said that that's actually not happening with the medications that we're throwing at delirium. So that's the first thing to say. And then I also love the distinction between understanding the target symptom, the hallucinations, and then agitation. But now I'm just going to ask you, I'm going to push you a little bit further. If we're talking about, say, a physical manifestation of a delirium, so say someone's very agitated and pulling out their catheter, and we're starting low and going slow, what, for a physical target symptom, what type of medication are we talking?
Then I think it's really what you're aiming to actually do. Is it actually a pharmacological restraint? Is it sedation? And how quickly do you want to do that? And what is the risk profile of a medication that you feel might be acceptable? to that person. And so, you know, sometimes if it's actually really around a safety concern, and you know, in an emergency department, that is sometimes the scenario that you just need immediate control just for a safety concern, so that you can actually start the IV antibiotics and the IV fluids and get on top of the infection so things start settling down. Then you might use a short-acting benzodiazepine unless there wasn't, if there was a contraindication for that, for example. If you're thinking about the driver of that behaviour being a hallucination and people responding to that, or feeling that, you know, if they've got a really significant delusion and they think they're being harmed, then you might use an antipsychotic. And, you know, more often than not, haloperidol gives you a range of routes, and that can be easy to administer. But then you might want an antipsychotic that has a bit more sedation. And so you really actually have to tailor it. And it can be quite complex to think about not just the benefits, you also have to think about what might be the harms of that particular choice in that individual. So if you have someone with Parkinson's disease, you have to take that into account, or if they have Lewy body dementia, for example, or if you're really worried that sedation in someone with chronic respiratory disease, for example, could be problematic, or they've got significant renal impairment, it can be a really fine balance. And that's why the lowest possible dose is another important part of the equation. And then you have to wait. I think the other thing is that these are medications that can take a few hours. So understanding the half-life and how long these things actually take to work is important. There's no point thinking that haloperidol is going to relieve a hallucination within 20 minutes. That's not how it actually works. Some of the psychiatrists that I've heard speak at Delirium conferences say it actually can take a day for the actual perceptual disturbance component of how an antipsychotic works to actually kick in. So giving repeated doses and more is just actually driving sedation. It's not actually changing the way it impacts perceptual disturbance. It's probably just masking it potentially, and the person might still be experiencing hallucinations. They just can't tell us or express that that's what they're experiencing. And we know that because a lot of the delirium recall studies, if you look at what they were treated during their delirium, many of them were on really quite large doses of antipsychotics, and they still remembered they had delirium and still remembered that they had perceptual disturbance. So
thanks, Mira. And I think probably the take home there for me is start low, go slow, right? It's interesting, right? Because actually we apply that to pain medications. It's kind of like a fundamental palliative care thing. But I hadn't actually connected it to that suite of medications. Tread carefully, in other words, really. Now, and I'm quite conscious.
You start it all, Sarah.
Oh, Annmarie, please. Is that
all I'd add to that is if you start at all. So
you started all. Yeah, totally.
So it's not just start low, it's do you start at all? That's what I think. Yeah.
And look, and I know, I think I liked what that Mira was saying about the target symptom as well. They need to be really well thought out, right? These medications, and very deliberate, if at all. Thanks, Annmarie. Now, I'm quite conscious of time, and we probably should have had another hour of this, but we can't. So I think what I would like to do for Annmarie, Amy, and Mira is just let each of you have a take-home message if you'd like to deliver to the group of 80-odd people who've stuck around, because it's clearly been interesting. It's been very, very interesting. So you might go Annmarie first. What would be the one take-home message you'd love the group to have before they leave today? Be optimistic about what we can do and what we might be able to do in the future, what we can do today. There are so many things we could be tackling with delirium care, and nurses are going to lead the way in so much of the care, I think, in terms of the fundamental care. So I think be optimistic and don't forget the value of the wonderful things that you can bring to people tomorrow. I love that. What about Mira? Mira, what's your take home?
I think information is power, that just telling someone what delirium is, why they have that, and their support people can be such a huge relief, and getting really familiar with explaining that to people is half the battle won. And it also means that we've taken the time to do the assessment and be confident that's what's happening for people, and shared decision making, that people with delirium are able to guide their care, and they know how they want to prioritise some of the things that we feel like the big tension in deciding, is it too much sedation, is it too much this? Now ask people and involve them in these decisions, and they will be quite able in many instances to be part of that decision and tell us what's important to them at any point in time.
Thanks, Mira. And Amy, what's your take home?
Use the word delirium, think delirium, but be kind to each other and support each other, because it's a huge toll being a nurse, caring for someone who is experiencing a delirium. So make sure that you debrief with each other, you keep using the word delirium in your handovers, you empower and encourage each other to continually be delirium detectives, to minimise that distress that the patient, their family and yourself are experiencing when caring for them. So that's probably my message, is look after yourselves as well.
Yeah, I think actually that's a lovely note to finish on, Amy. It is the impact of this can be big, right? And it's about supporting each other, you know, and working as a team. So look, before you all leave, I just firstly want to say thank you to Annmarie, Amy and Mira. I certainly learned a lot, and I just love that we can get together as a bunch of palliative care nurses and do a bit of learning from experts like yourselves. So thank you very much for your time. If you are not a member of PCNA, please think about joining us, because there's a library full of really, really great webinars like this. Last one was on nausea from Jenny McKenzie, and you can watch it anytime. The next one, we've got the next few webinars are very, very interesting, about deprescribing in palliative care, and Josh Collins doing another one about tricky pain. So please continue to join us on a Wednesday afternoon. So thank you, all of you, and have a lovely, sorry we didn't get to your questions, that we just had too many questions and not enough time. But anyway, thank you very much, everybody.